Now for today's presentation, please join me in welcoming Erica Ravenwood, who is presenting an introduction to gender dysphoria, one veteran's perspective. Erica is an artist, author, public speaker, civil rights activist, and veteran. She strives to bring awareness to the population at large as to what it is to be transgender in hopes of ultimately receiving not special treatment, but equal treatment under the law. Erica is joining us via phone this morning, so I will be driving the slides. And Erica, I'm now moving on to your second slide, which is the definition diagram, and the floor is yours.
Thank you very much. It's great to be here. I'm going to go through quite a bit of information, some that you may think, well, it doesn't really pertain to me being a medical person, but it all does play into it. I'm going to go through some of these things rather quickly because at the end I want enough time for questions. I find within this topic there are quite a few questions. There's a lot that just isn't known. So to start off with, the reason we need to start learning more about transgender patients and how to treat gender dysphoria is because there will be an influx. And right now it's estimated that only 0.5% of the U.S. population is transgender, but that the worldwide estimate is as high as 5%. This suggests not that there is a lower number of transgender people in the U.S., but that we have a much more closeted transgender population than other parts of the world. As understanding through education grows in the general public, the fear that transgender people feel will lessen and more will seek help. So because of that, we need to be prepared for this influx. Now, as you're looking at the chart in front of you, I've given a series of definitions in a flow chart. The thing to note is that I've given transgender a definition. Historically, this word was only used as an umbrella term that referred to any number of gender variances. However, it has become the word that has permeated the social consciousness and deserves a clearer definition. The definition that I've given you is closer to the presumed definition that most people have for this word. Being transgender is basically a lack of alignment between the person's gender and their sex. By contrast, a cisgender person's gender and sex are aligned. You'll notice on the chart that under the term transgender, there are several gender types, 2 which are consistent and 2 that are non-consistent. Gender expression under my definition is a separate thing and doesn't fall under the term transgender. A person's gender expression doesn't determine their gender any more than it does for a cisgender person. And I'll go more into that under gender expression later. Can we go to the next slide?
Yep, you're all set.
All right. With this slide, what this demonstrates is the cisgender perspective of gender and sex. This is what we normally think of. This is what we've been taught our whole lives, is that gender and sex are basically the same thing. And the reason being is because for the cisgender person, they align. And it's difficult to recognize this separation between the two. For a transgender person, their gender and sex do not align, and this separation is very obvious. It's the lack of alignment that causes most gender dysphoria. The thought that gender is determined by the mind and not the body is a strange concept for most people. The majority of the world, after all, is cisgender. For most people, there is no need to think of sex and gender as being separate things, and the two words are very often used interchangeably as if they are the same thing. Can we go to the next slide?
Yes.
Yes. All right. Now, as you look at this slide, this is a representation. of that separation. If you would raise both hands to your eye level and call one your physical presence, that represents your body, your sex. It also represents your outward expression. It's your physical presence. And the other hand is your gender. You'll be able to see a representation of the separation between these two things that exists, whether you're cisgender or transgender. The separation of sex and gender exists in everyone. It's just that when you're cisgender, you don't see the separation. When they align, it's difficult to recognize the separation, and often we are told sex or physical presence and gender are basically the same thing, since people feel no discomfort when they are aligned. Separate them and you will see how different they are. This lack of alignment is what causes gender dysphoria. The treatments for transgender people are designed to bring these two things closer to alignment in order to alleviate this horrible discomfort. People who have a gender thought process that moves from male to female and back again experience gender dysphoria that goes away when their physical presence, what their physical self is, aligns again with their gender. So the management of gender dysphoria is not a one-size-fits-all. And if there are any questions during this, I'm more than happy to. Can we go to the next slide?
Yes.
All right. Now, what is gender dysphoria? Dysphoria itself is a feeling of unwell, unhappy, depression, anxiety, or indifference, a feeling of emotional or mental discomfort. Gender dysphoria, in its basic sense, is defined as a negative feeling toward one's current gender presentation. That is what's listed in the books, but that is a much too simplified presentation of the term. Depending on the degree and persistence of the gender dysphoria, it can manifest into a form of chronic depression, and it can include a high physical revulsion to one's secondary sexual characteristics. If left untreated, gender dysphoria can in some cases lead to forms of severe mental illness due to the high degrees of persistent stress. Being transgender is not itself a mental illness any more than being transgender is. Gender dysphoria is a treatable byproduct. Now, just to let you know, I knew that I was transgender when I was 3 years old. I knew that how I was being treated, how I was being addressed, was inconsistent with my gender. Even though at 3 years old I didn't know these words. But I was quite aware. And so it's been a lifelong thing for me, as it is for most transgender people. And we can go to the next slide.
Okay.
All right. Now, the treatment for gender dysphoria is unique in that it crosses over between the mental health and the medical sectors. It requires an interaction between the two, unlike most ailments that would be treated by one or the other. And we can go to the next slide.
Okay.
Now, what I'm going to be discussing here is gender dysphoria, but this is information that I've put together through my own research. And in trying to explain what gender dysphoria is. So, within gender dysphoria, I talk about personal centers. There's personal centers of gender dysphoria. Gender dysphoria is not a one-size-fits-all for all people, even though most of the treatment that we have set up now is kind of a one-size-fits-all. Each person who suffers from it has what I call dysphoric centers. As you will note on the scale, at one end is the body, and at the other end is self-expression. Most transgender people feel gender dysphoria due to both a disconnect between their body and their gender, and a lack of ability to exhibit natural and preferred self-expression. Myself, for example, might have a much higher degree of gender dysphoria associated with denied self-expression and relatively little to do with my body versus the next transgender person whose gender dysphoria centers most heavily for them around their body. And I'll give you a more clear, deeper example of that. When I decided to come out, and I will go into later how most transgender people never really come out of the closet, but I decided this last time, because I lived 3 years full-time before, that I was going to come fully out of the closet. I don't care if everybody in the world knows that I'm transgender. For me, when I did that and adopted my preferred self-expression, I would say 80% of my gender dysphoria went away. And the rest is going to be addressed medically through HRT, through an orchiectomy, and things of that nature. So that's how my personal center is set up, but it's not the same for everyone. Can we go to the next slide?
Yes.
All right. Now, I've broken down gender dysphoria into 3 distinct types, and I don't want anybody to think that a transgender person only has one type of gender dysphoria. They don't. Most transgender people have a combination of all 3. It's just that their centers are different, one leaning more heavily to one than the other. There's also, because there are different gender types, not everybody is binary. And back on that chart, and if you wanted to refer to the definitions later, there's something called binary. And binary refers to a person with a fixed gender, either male or female. I would be considered binary transgender female. My gender is consistent and always has been female. There are other people, though, who are gender fluid or gender queer, and their gender moves. And so within treatment, their treatment would be different than what mine would be. So within type 1 gender dysphoria, these symptoms center around self-expression. And this type can potentially be cured or managed through allowing the mind its natural flow of self-expression. I have very little, at this point, any type 1 gender dysphoria issues. Let's see. And I want to talk for a second about what stealth is. Even though a patient may be seeking treatment, it doesn't mean they're out of the closet. Most transgender people never actually come out of the closet fully. Many would like to transition and never have it known that they are transgender. So they take a step out of the closet in order to seek treatment. And that's important to understand when a transgender patient is coming to see you. Not all of them are out, not all of them wish to be known as transgender at any point in time in their life. Can we go to the next slide?
Yes.
Now, this is a chart that shows gender expression. Gender expression doesn't determine someone's gender. It doesn't determine the gender of someone who is cisgender any more than it determines what is the gender of a transgender person. Gender expression exists on a sliding scale. So there shouldn't be a preconceived idea of the gender expression a transgender person should have, particularly females. Just like cisgender women who exhibit a wide range of gender expression, from more feminine to more masculine, a transgender woman is no different. I have many transgender female friends who are tomboys. This doesn't mean they shouldn't be treated as any other woman is according to her gender. Rather than thinking in terms of this person as being transgender, whether male or female, it is actually much better to think of them as being cisgender. and interacting with them just as you would anyone of that gender. And this is more just the interaction part of it. If their gender is known, treat them as you would anyone else of that gender. Typically, we treat men and women differently when we interact with them. So if you know that the person's gender is female, just treat them like you would any other female. If you know that their gender is male, then treat them like you would any other female. Now, I understand there is some difficulty if what you're seeing is not what the expectation is. And I understand that, but that's kind of the cross to bear. And throughout the transition process, their presentation will probably more than likely change anyway. But their desire to be treated as in accordance to their gender doesn't change. And can we go to the next slide? Unless there's any questions on that.
I don't see any questions typed into the chat box, and so I think we can proceed, and I'm on the next slide.
All right. So now we have type 2 gender dysphoria, and this kind of gets into the nuts and bolts of what you all are probably more interested in. And type 2 centers around symptoms that are of the physical body and can be treated medically. Medical treatments can include hormone replacement therapy, sex reassignment surgery, either male or female, mastectomies for transgender males, orchiectomies for transgender females, and or cosmetic surgeries such as laser hair removal, implants, facial surgery, these type of things. And these are dependent only on the individual's feeling of need. Right now, HRT is the only medically offered treatment other than a continuance for the patient to be seen within the VA system after sex reassignment surgery is done, if the patient so chooses to have it done outside the VA system. So basically that just means you will address the patient's current needs regardless of where in the process they are with transitioning. Treating a transgender patient creates a crossover as well in terms of things that would be offered within an exam or included in the patient's well-being. For example, my body, I've had no surgery, I'll just let you know this. I'm on HRT, I have been for almost 2 years. I've had no surgery. I don't plan on having sex reassignment surgery. For me, it's not needed within my gender dysphoria makeup. So right now, my body remains male in many regards. So because my body remains male, I'm over 50, I should have a prostate check just like any other male over 50. I also have breasts due to HRT and should have regular breast exams. My needs are different than either a cisgender male or a cisgender female who you would normally see. There are typically more things to check and not less. And it would be helpful for both the doctor and the patient to be aware of those things to reduce those awkward moments. Can we go to the next slide?
Sure.
Sure. Now, most typically, it's the binary transgender person who you're going to be seeing. The binary transgender person has a fixed gender of either male or female and a body that is opposite of that. So they're the ones who are more times than not going to be seen for medical treatment. But that it's not exclusive to that. You have gender fluid, gender queer. They may make a determination that for their treatment plan, there may be some medical treatments as well. But most typically, you're going to be seeing the fixed gender person. So as long as you know what their gender is, then you're going to be able to, it really does make it easier. It's really more easy, it's easier to interact with somebody who has a continuance and is always the same for you rather than somebody that changes. Does anybody have questions in this area? Now this is this type of gender dysphoria is really the one that you're going to be seeing most. Does anybody have any questions in this area before I move on?
I will just remind everyone that your lines are open. We have not muted the audience, so you can unmute yourself to ask a question, and then also we have the chat window in the lower left-hand corner, so you can feel free to type in questions as the presentation moves forward. But Erica, right now we don't have any in the chat window for you.
All right, sounds good. Let's go to the next one. And,
Okay.
all right, now this is type 3 gender dysphoria. And this will go back to being addressed through mental health for the most part, as is type 1. These are symptoms that center around physical attributes that cannot be changed medically or through cosmetic treatments, such as height, shoulder width, basically all skeletal structures. To give you an example, I'm very tall. I'm over 6 feet. It used to give me horrible gender dysphoria. And the reason being was because I associated my height with a very male feature. And my height is not going to change. It's never going to change. So in order for me to get over that, and I did get over it, I had to change how I saw that physical attribute. So no longer do I see my height as being specifically male and giving me gender dysphoria because I'm female. I now see myself only as a very tall girl. Shoulder width is something I'm still working on. My shoulders are broad. There's skeletal structure as far as bigger hands, things of that nature that cannot be changed or altered really, that I'm just going to have to really get good with. And that all falls under type 3 gender dysphoria. Activities are the same way. There were activities in the past that would give me gender dysphoria, such as a thought that I had to enjoy football, for example. And it created gender dysphoria for me because I felt like I was supposed to be male, supposed to be seen as male, and I was supposed to like this. Well, now I've altered my view of that activity, so I can take interest or not, and nobody cares because they all see me as female. So anyway, that all falls under type 3 gender dysphoria. I think I actually kind of skipped over the next slide, but that's okay. We can go past it.
So do you want me to advance 2 slides?
Yeah, take it down to gender dysphoria is also caused by...
Okay, we're there.
All right. And this is really going to talk about the interactions with a transgender person. Gender dysphoria is also caused by the way a person is treated by others. And I'll talk about my own personal experiences within treatment. In my day-to-day life, there are very few reminders really that I am transgender. I go shopping, I go to different places, and quite honestly, most people don't even realize. When I come in to have treatment, to have tests done or whatever, it all comes back. It's very glaring. There's constant reminders to me that yes, in fact, you are transgender. Being treated in a way that is inconsistent with their gender is extremely painful, regardless of whether or not the person has expressed their gender or not. So when I was in the closet, even though it was nobody's fault, I looked male, I sounded male, I acted male, there was absolutely no reason why people shouldn't have treated me as male. We do these things out of respect. But for me, it was still painful. When I came out of the closet and, at least made my gender known, then being treated in a manner that's not consistent with that gender is now insulting. Can we go to the next slide?
Yes.
All right. And some examples of what not to do. And again, now I'm going. Before I even get into this, I'm going to preface this. The encounters that I have now in my life, when I meet somebody for the first time, they only know me as Erica. They've only ever seen me look female. So there's less chance of mistakes being made. They're not going to call me my old name because, they don't even know my old name. But using pronouns that are inconsistent with the person's stated or preferred gender is kind of a don't do. People that worked with me before I started transitioning were making the most trips, the most mistakes. I was actually at an appointment at one time and dressed very nice, I thought, and I was asked to come into the office with, "Sir, come on in, sir." Well, to me that just stung. That really hurt. So that's something to really try to avoid. Using a name that is other than the preferred name. If you know the preferred name, it really goes a long way if it's used, even if it's not in the system. Now, if it's not in the system and I'm in the waiting room and I'm waiting for the nurse to call my name, it's reasonable to think she's going to call the name that's on that chart. But if the preferred name is known, it really does go a long way to validating who the person is. I wrote a piece on names and the importance of it. And for a lot of transgender people, they've known their name much longer than anybody else has. It was their way of giving them a sense of self. And that name is extremely important. So if the name is known, regardless of whether it's on the record or not, if it's known, then it really needs to be used. And then the third thing I have here is commenting on appearance in a way that wouldn't be a normal comment to make to anybody of that gender, even if it's meant as nice. And I'll give an example of something that was said to me. You're looking more feminine. That's an unusual comment, and it would not be said to any other woman. We don't walk up to women and say, "Wow, you're looking more feminine today." So those things, even though they're meant nicely, they do hurt because it makes it glaringly obvious that everybody knows you're transgender. And those are things that we need to try to avoid if possible. And, wow, I'm almost done. Yeah, let's just go to the next slide. And I want to let you know, too, I understand that there's really nobody here that has the power to change policy within the VA. But I do want to kind of make a plea for extended treatment within the VA. Right now, we're offering, through the February 2013 directive, mental health and HRT. And it kind of, it's kind of a halfway thing. Having a patient sit in limbo and only on HRT is not good for them. It's not healthy. And there are procedures that are within the skill set of our VA surgeons that can be offered. Orchiectomies, mastectomies, these are things that are done on a regular basis. They're just done for other reasons. And to expect sex reassignment surgery to be offered would be unreasonable. That's a very specialized skill set involved. But orchiectomies and mastectomies are done within the VA often. We can go to the next slide. For many transgender people, one or the other of these procedures would resolve most or all of their type 2 gender dysphoria issues pertaining to surgery. For transgender females, the orchiectomy eliminates the need for spironolactone, a testosterone blocker. It would reduce or eliminate the need for estrogen, both of which would reduce or eliminate certain health risks associated with HRT. And that's my last little thing. We can go to questions in just a second, but I do want to, since I have, I'm sure, a lot of people here, I think it would be beneficial if a pamphlet were created, just your standard trifold pamphlet that we always see, of what to expect within the exam room, and for both patients and doctors. I know for myself, going through starting this process, nobody sat down and explained to me anything. Everything I had to kind of figure out myself, and there were those awkward moments, and there continues still to be those awkward moments of being in the exam room, and they're like, well, wait a minute, I have to think about it. What am I checking for you? If the patient knows going in, it's helpful because there are no surprises. If the doctor knows before the patient comes in, of course, there's less awkward moments. I also know that understanding what it is now that I might expect within an exam, I dress appropriately and in a way that's going to make me more comfortable throughout that exam. So I'm going to ask this. I have contact information that's going to be at the end here. And if there's anybody that would like to volunteer their medical expertise, and we can, and just give me some information, then I can start working on that pamphlet. And with that, I will take questions.
Great, thank you, Erica.
Sure.
Again, I know some of us have joined throughout the course of the presentation here, so the chat window is available for you to write in questions, but lines are also open, so feel free to unmute your line to ask a question as well. So there are two methods within you can ask a question. So.
While we're waiting for questions, there was one thing that I was going to talk about and I forgot. But this is important as well. I'm going to talk about sexuality. There tends to be an assumption that transgender people are all gay, or there's a certain presumption about sexuality. Most cisgender people give themselves a sexuality label based on body parts. Many transgender people give themselves the sexuality label based on their gender. Like I've stated, I have not had any surgery, but I view my sexuality through my gender because that's how I view myself. So, being that I do like guys, I always consider myself straight. Now, what label somebody else gives me, that's completely up to them. But that's how transgender people, by and large, tend to think. So if you're going to ask a cisgender patient about their sexuality for medical reasons, then that's fine. If not, then you don't need to ask your transgender patient either. medical reasons for knowing someone's sexuality is because the patient feels they should be tested or already have something that would be of concern. This is true for your cisgender patient or your transgender patient. They're going to tell you that they have that need. To make the assumption that because a person is transgender, they are probably promiscuous or practice unsafe sex, or anything of that nature. This is kind of rude, don't you think? So you have to ask yourself, are you asking the patient about their sexuality out of curiosity? Or is there a need for the treatment of the patient? I know that I've been asked about my sexuality quite often, and it really didn't pertain to anything. It was just really out of curiosity. That's all I have on that.
Thank you for speaking to that, Erica. This is Kate, and I think that's something that trips up a lot of people, so I'm glad you mentioned that.
Yeah, unfortunately there's, we're joined by the acronym with the LGB. And so people make the association that, well, it's LGBT, so it must all be sexuality, but it really isn't. LGB is sexuality, gay, lesbian, bi. Transgender is an identity. And your gender doesn't determine your sexuality being cisgender any more than it does being transgender. I could like guys, girls, or sock puppets just like everybody else.
Thank you, Erica. And we just have one comment.
Sure.
Thank you for a very enlightening presentation. And just a question came up. Since we've moved to the patient-aligned care team within primary care over the last several years, and that more kind of medical home concept for patients, have you seen any changes, positive or negative, as it relates to being transgender? Since this change occurred, since we're trying, we're working in a more team approach in primary care.
Absolutely. I mean, the directive for transgender patients, like I said, it came out in February 2013, and I went into the VA system being transgender in 2007. My experience during that time, people were nice to me, but it was never addressed. It was almost as if people were trying to avoid the idea that I was transgender. I was addressed as female, I was treated as female, but I was given no medical treatment or even offered it. It was suggested I go see OBGYN. But nobody really knew. So after this directive, the second time that I went back into the system, and I made my decision to transition the second time in 2013, late November. The change has been incredible. And I do see more of a interaction between the different departments. And particularly, like I was saying, with gender dysphoria, it's unique in that the treatment of gender dysphoria crosses over between the mental health into the medical sector in order for it to be treated. And I really do see, in what I've experienced anyway, I do see that crossover. I do see people talking to each other, which is great.
I'm glad that was your answer. I was hoping you were going to say that.
Yeah, no, you're
anyone else?
We're moving in the right direction,
absolutely. For Erica.
Even if it's something for curiosity's sake, you can ask me, as long as you have me here.
So, and this is Lynn Wetterell. I think I very much appreciated this presentation. I have to confess a lot of ignorance about the underlying cause, and this has helped my understanding a lot, so thank you for that. I wondered, having served in the military, are there issues, we talk a lot about military sexual trauma. Does that come into play at times?
Yeah, for myself, no, I've never had any sexual trauma. My experience in the military, I served from 86 to 91. I was in the infantry. And really my reasoning for joining was I was running from my gender. I was trying to get as far from myself as I could. And so everything I did really went against my nature. I served as a scout, I trained as a sniper, I got accepted to Special Forces training. All these things were to go as far to the extreme of trying to show myself as male as I possibly could. The difficulties that I had, I could do the job, but the difficulties I had were trying to interact with people afterwards during downtime or after the mission was over. I couldn't relate to guys, and the reason being was because I don't think like a guy. And it was difficult because I was seen as a guy, and this is the problem I've had my whole life. I've always been seen as male and therefore expected to think and act male. But it goes against my nature. Now, being seen as female, I can interact with males just fine because the expectation has changed. I'm not sure if that answered your question or not.
Thank you. No, that's good.
It is good. And, sorry, Eva. No, go ahead. I just want to point out again that it's also important to know that questions of identity like this aren't developed in a response to trauma. You knew at the age of 3 that you were really female, and that was...
Oh, absolutely, yeah. Right. What was that the question? A question about whether or not somebody becomes transgender as
I don't think it was my question, but I just want to take this opportunity to dispel that myth.
Right. Yeah. Exactly. The reason I say 3 years old is because that's kind of the age where I became self-aware. My first couple years, 3 to 5, before I started school, I was pretty much allowed to do whatever I wanted to do, and I just did whatever was natural for a little girl to do, without anybody really saying, well, you can't do that. It was right before I started school that they said, well, you can't do that. And it was when I started kindergarten that my gender dysphoria actually started. I had never really spent much time around other children, and so at this point, being segregated away from the girls and stuck with the boys very often, there was that sense, even at that early age, that this is not right, something's wrong. Now, how, navigating that, I spent the next, 40 years trying to navigate how to deal with that. But the knowledge was always there.
Okay, great. Well, we don't have any more questions typed into the chat box. I'll open it up one more opportunity for any questions. We've got a big group on, but they're a quiet bunch today,
They are a quiet bunch.
So, but any other questions or comments for Erica before we close for the day?
I'm sure there's got to be some curiosity. Some questions.
But we have someone typing.
There we go.
So we'll hang tight for a minute.
Sure. Yeah, just, so people know, for myself, and I know this is true for most, particularly transgender women, that male persona, it is just that. It's a persona. It's this front that I put up in front of myself. And because there was that front, it created all kinds of issues as far as interactions with other people and just being able to try to navigate life in general. But then, in addition to that, having severe gender dysphoria. Again, like I said, because I'm binary female, my gender has never changed. It's always been female. My gender dysphoria was persistent. It never really went away until I started treating it. And part of, prior to seeking medical treatment, I was treating it as type 1 and through expression. But that was very closeted and very limited. For people who are gender fluid, their gender dysphoria tends to come and go.
Okay, Erica. Comment and question.
Sure.
Appreciate your presentation. Did you have family support?
I do now. I have children. I was married for years. I have children. I have grandchildren. There's varying support. There is support. It's a difficult situation, though, for everyone, quite honestly. There's a lot to process. But the support system is vital, and let me touch on that. In order for someone to transition, it cannot be done in a vacuum. They have to have a support structure, a good support structure. And that support structure can come from family and friends, but it also you need to be part of that support structure as well. And what you're doing is, now the person is coming out, they need to have validation for those feelings that are coming out, because up until this point, they've been made to feel that they're wrong in being who they are. And so that validation is incredibly important in order to allow that person to understand that that's not the case. They're fine. And I completely missed the question, didn't I?
No, you addressed it. And then we also have one of our primary care providers has asked, how in primary care can we identify what gender the patient is expressing?
Yeah, gender really only exists. I mean, we only know someone's gender through their proclamation. I am female, I am male. That's really the only way we know that somebody's gender identity. Gender identity is something that's unseen, even for a cisgender person. We just tend to assume people's gender based on what we pick up, either through their gender expression or physical traits or whatever. It really comes to that self-declaration. Now, is the question, how do I know beforehand?
I would assume so. She's typing yes.
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 Well, I was talking to Kate about this. It would be great if there was something available within the system that would allow people to understand that they are transgender, because there are different needs. I know that in my records it still says M as the sex designator. So if you were to just look at my chart, of course it says Erica Elizabeth Ravenwood, so it probably would cause some question, or maybe enlightenment. But not everybody changes their name legally, particularly early on. So it would be helpful if there was something in the system that would say, okay, this person is transgender female or transgender male, such as TF or TM, allowing you not only to understand what their gender is, but understand that they are transgender and that their medical needs are different than a cisgender male or female. But that's not something that exists in the system at this time, from what I understand.
And Kate has also typed in to the comments that this also comes into play with clinical reminders, which are many of which are triggered by demographic information. So like you had mentioned the PSA, the prostate screening, and other things that, depending on the situation, may not be triggered.
Right, yeah, exactly, yeah.
What's in the chart and what the gender expression is.
Because you're right now the system is placing the demographics solely on either a cisgender male or a cisgender female. And so the medical requirements for those things based on age and whatever. For the transgender patient there are differences. Even if I were to have sex reassignment surgery, there's still, physiologically, there are things about my body that are always going to be male because my chromosomes are XY. So it creates a different need. And these are things that I can't give you the answer today because there is no answer. These are things that should be changed in the system, that can be changed in the system. We just need to figure out what would be the best.
Well, thank you very, very much, Erica, and it was a great presentation, a lot of information. I have the slide up right now with your contact information, so if anyone is interested in reaching out to Erica and helping her put together that pamphlet, her email address is up on the screen, as well as a Facebook page and some informational videos that are available.
Yeah, I'd like to offer too.
Rounding in at the end of the hour. Again, thank you very much for taking the time to share this information with us.
Thank you.
This